Hi class, welcome. Dr. Fife here. Today we're going to cover the cellular environment, fluids and electrolytes, acids and bases. We'll get started with the distribution of body fluids. Fluids in the body are distributed among functional compartments or spaces and provide transport medium for cellular and tissue information. Water moves freely among body compartments and it is distributed by osmotic and hydrostatic forces. We have intracellular fluid, or ICF, which is 2/3 of the body's water is ICF. Extracellular fluid, or ECF, is 1/3 is ECF. Two main functions of the ECF compartments are interstitial fluid and intravascular fluid, or the blood plasma. Other ECF compartments include the lymph, saliva, intestinal, biliary, hepatic, pancreatic, and cerebrospinal fluids. Sweat, urine, pleural, pericardial, and intraocular fluid are all also extracellular fluid. The sum of all fluids within all body compartments constitutes the total body weight, or TBW. The body regulates water volume within a relatively narrow range, and water movement between the ICF and ECF is primarily a function of osmotic forces. Distribution of water and movement of nutrients and waste products between plasma and in tissue capillaries and interstitial spaces occurs as a result of changes in hydrostatic pressure and osmotic forces at arterial and venous ends of the capillary. One of the common symptoms we see in patients is edema. So what's going on here? Well, we have alterations in water movement. And edema is that excessive accumulation of fluid within interstitial spaces. This is often a problem of fluid distribution and not necessarily fluid excess. Pathophysiological process of edema is related to an increase in the forces favoring fluid filtration from the capillaries or lymphatic channels into the tissues. The four most common mechanisms are increased capillary hydrostatic pressure, or venous obstruction or sodium and water retention, decreased plasma oncotic pressure, which results from losses or diminished production of plasma albumin, increased capillary membrane permeability, which is usually associated with inflammation and the immune system, and lymphatic obstruction, in which lymphatic channels are blocked, and this can be due to an infection or a tumor. Edema may be localized or generalized. Clinical manifestations: the patient may feel swollen, may have some puffiness, they could complain of their clothes or shoes feeling tighter. Weight gain can be pretty significant, and edema can cause wounds to heal more slowly and cause pressure sore formation risk to increase. Edematous fluid accumulates and is trapped in third space or interstitial space, and dehydration can develop as a result of sequestering of fluid. And here's just an image showing no edema compared to edema and how it looks with pitting. Sodium, chloride, and water balance. The kidneys and hormones have a central role in maintaining sodium and water balance. Because water follows the osmotic gradients established by changes in salt concentrations, sodium and water balance are intimately related. Sodium and chloride balance. Sodium accounts for about 90% of extracellular fluid cations. Along with constituent anions, chloride and bicarbonate, sodium regulates extracellular osmotic forces and therefore regulates water balance. Sodium is important in other body functions: neuromuscular irritability for the conduction of nerve impulses, acid-base balance, cellular chemical reactions, and transport of substances across cellular membranes. Hormonal regulation of sodium balance is mediated by aldosterone. When circulating blood pressure and renal blood flow or serum sodium concentrations are reduced, renin is released. And what is renin? Well, renin is an enzyme secreted by the juxtaglomerular cells of the kidney. And remember, that's released when the blood pressure, renal blood flow, and serum sodium concentrations are reduced. Renin gets released. Renin stimulates formation of angiotensin 1, which is an inactive polypeptide. Angiotensin converting enzyme, or ACE, in the pulmonary vessels converts angiotensin 1 to angiotensin 2. Angiotensin 2 has two major functions. It causes vasoconstriction, which causes the blood pressure to go up, and it stimulates the secretion of aldosterone. Aldosterone, now this promotes sodium and water reabsorption by the proximal tubules of the kidney. So this helps to conserve sodium, blood volume, and blood pressure. Natriuretic peptides, these are hormones that include atrial natriuretic peptide, or ANP. This is produced by the myoendocrine atrial cells, and brain natriuretic peptide, which is BNP, produced by the myoendocrine ventricular cells and urodilation. ANP and BNP are released when there is an increase in transmural arterial pressure caused by an increased intraatrial volume, as may occur with heart failure. Fluoride is a major anion in the ECF and provides electroneutrality, particularly in relation to sodium. Fluoride transport is generally passive and follow active transport of sodium, so that increases or decreases in fluoride are proportional to changes in sodium. So they go hand in hand. A water balance, one manner of water balance is regulated through the perception of thirst. And thirst is that sensation that stimulates us to drink some fluids. Thirst is experienced when the water loss equals 2% of the individual's body weight and when there is an increase in osmolality. Symptoms can be a dry mouth, hyperosmolality. There is plasma volume depletion, activate hypothalamic osmoreceptors, and the action of osmoreceptors cause thirst. Water balance also is directly regulated by the antidiuretic hormone, which is secreted when plasma osmolality increases or the circulating blood volume decreases and blood pressure drops. With fluid loss or dehydration, a decrease in blood volume and BP often occurs. Baroreceptors stimulate the release of ADH. Reabsorption of water mediated by ADH then promotes the restoration of plasma volume and blood pressure. ADH also stimulates arterial vasoconstriction. This picture here is just showing the different composition of body water, the different parts of the body. Alterations in sodium, chloride, and water balance. Alterations in sodium and water balance are closely related. Water imbalances may develop because of changes in osmotic gradients caused by a gain or loss of salt. Sodium imbalances occur with alterations in body water volume. Alterations can be classified as changes in tonicity or the change in concentration of electrolytes in relation to water. Isotonic alterations. Isotonic refers to a solution that has the same concentration of solutes as the plasma. Isotonic alterations occur when changes in TBW are accompanied by proportional changes in the amounts of electrolytes in water. Isotonic fluid loss results in hypovolemia, and causes of this include hemorrhage, severe wound drainage, and excessive diaphoresis or sweating. Loss of extracellular volume results in weight loss, increased hematocrit value, dryness of skin, and the patient can have symptoms of hypovolemia. When there's severe alterations, this can cause hypovolemic shock. Isotonic fluid excess results in hypervolemia. Causes include excessive administration of IV fluids, hypersecretion of aldosterone, and effects of drugs such as cortisone, and in renal failure. Patient may have weight gain, a decrease in hematocrit level, and plasma protein concentration caused by diluting effect of excess plasma volume. Neck veins may be distended, and the patient may have an elevated blood pressure. Now, hypertonic alterations, these develop when the osmolality of the ECF is elevated above normal, greater than 294. Most common causes are increased concentration of ECF sodium or hypernatremia, or a hypernatremia, or a deficit of ECF-free water. Hypernatremia, sodium levels exceed 147. This is caused by loss of water or an acute gain in sodium. With water loss, ICF and ECF dehydration occurs. Hyperosmolality is a common result of hypernatremia. Fever or respiratory tract infections, diabetes insipidus, polyuria, profuse sweating and diarrhea, all can lead to hypernatremia. Infants with severe diarrhea are particularly vulnerable to this issue. Increased sodium retention occurs due to inappropriate administration of hypertonic saline solution, or it can be due to an oversecretion of aldosterone, or from Cushing syndrome. Clinical manifestations, here's a chart showing signs and symptoms. You can remember that with this mnemonic of fried salt. Treatment is going to be isotonic salt-free fluid, 5% in dextrose and water, until the sodium level returns to normal. And it's important that these fluids are replaced very slowly because you want to prevent cerebral edema. Hyperchloremia, because the chloride follows sodium. Hypochloremia, which is a level greater than 105, often accompanies hypernatremia, as well as plasma bicarbonate deficits, as in hyperchloremic metabolic acidosis. Treatment is to treat the underlying disorder. Water deficit, dehydration refers to water deficit, but is commonly used to indicate both sodium and water loss, isotonic and isoosmolar dehydration. Pure water deficits, hyperosmolar or hypertonic dehydration, these are rare because most people have access to water. Patients at risk for this are comatose or paralyzed patients who have insensible water losses through their skin and lungs. Hyperventilation caused by fever can also be an issue to cause this. Most common cause of water loss is increased renal clearance of free water as a result of impaired tubular function or inability to concentrate urine, such as that which occurs with diabetes insipidus. Clinical manifestations, the patient could have symptoms of dehydration, including headache, thirst, dry skin and mucous membranes, weight loss, decreased urine output, and concentrated urine. There's a chart here just showing some more of the symptoms there. Evaluation, elevated levels of hematocrit. We can have serum sodium concentration, urine and serum, osmolality, and urine-specific gravity are different things to look at here. Treatment is to give water to stop fluid loss. Replace fluid slowly because that rapid movement of water into the brain cells can cause cerebral edema and lead to seizures, brain injury, and death. So you want to treat this fluid replacement slowly. Hypotonic alterations, imbalances that occur when the osmolality of the ECF is less than normal or less than 280. Most common causes of sodium deficit are hyponatremia or free water excess, water intoxication. Both causes lead to intracellular overhydration or cellular edema and cell swelling when water moves into the cell where osmotic pressure is greater. Cerebral and pulmonary edema occur in conjunction with these fluid shifts. Now, with hyponatremia, the plasma volume then decreases, leading to symptoms of hypovolemia. And with free water excess, the ECF volume is elevated, causing symptoms of hypervolemia. With hyponatremia, the serum sodium level is going to be less than 135. This is the most common electrolyte disorder in hospitalized patients. This is caused by sodium loss, inadequate sodium intake, or dilution of the body's sodium level. Times where this might happen is with the syndrome of inappropriate secretion of antidiuretic hormone or failure of the distal tubules to reabsorb sodium. Pure sodium deficits usually caused by diuretics or extrarenal losses such as vomiting, diarrhea, GI suctioning, or burns. Hyponatremia may cause hypotonic or hypertonic alterations. Clinical manifestations, there's cellular swelling and deficits of intracellular sodium can alter the ability of the cells to depolarize and repolarize normally. So neurologic changes, the patient may have lethargy, headache, confusion, apprehension, seizures, or coma. And here on this image, it gives a mnemonic salt loss as a way to remember those symptoms. Evaluation of serum sodium level is going to be less than 135. Hematocrit plasma protein levels may be elevated. Treatment is related to the contributing disorder, restriction of water intake. Hypochloremia goes along with this. The low level of serum chloride is less than 97. This occurs with hyponatremia or elevated bicarb concentration, such as with metabolic acidosis. Serum deficit related to restricted intake, use of diuretics, and vomiting are accompanied by chloride deficiency. And one disorder is noted here is cystic fibrosis. This is a genetic disease characterized by hypochloremia. Water excess. This is when the body is functioning normally, it's almost impossible to produce excess of total body weight since water balance is regulated by the kidneys. Water intoxication can occur from compulsive water drinking. Intensive exercise and replacement of large volumes of electrolyte-free water can cause overhydration. Acute renal failure, severe CHF, and cirrhosis can all precipitate water loss. Decreased urine formation from renal disease or decreased renal blood flow can contribute to water excess. Clinical manifestations, the patient might have some cerebral edema, which can cause confusion and convulsions. The patient may have weakness, nausea, muscle twitching, headache, and weight gain. To evaluate this, we're going to check the blood, the serum sodium decreased, serum and urine osmolality is decreased, and the urine sodium concentration is reduced. Treatment, restrict fluids for 24 hours, may give small amounts of an IV hypertonic sodium chloride. These can be given when there's neurological symptoms that are severe. Alterations in potassium, calcium, phosphate, and magnesium balance. Potassium is a major intracellular electrolyte and is found in most body fluids. The ICF concentration is 150 to 160, and the ECF concentration is 3.5 to 5. Potassium balance is maintained by renal excretion of potassium absorbed from the GI tract. Absorbed dietary potassium moves rapidly into the cells, and the distribution of potassium fluctuates. Aldosterone, insulin, epinephrine, and alkalosis, and glucagon blocks entry of potassium into cells, and glucocorticoids promote potassium excretion. Aldosterone is a major factor in potassium regulation. Insulin contributes to the regulation of plasma potassium levels by stimulating the sodium-potassium ATPase pump, thereby promoting the movement of potassium into liver and muscle cells. So insulin can be used to treat hyperkalemia. Kidney provides most efficient regulation of potassium balance over time. Potassium is freely filtered by the renal glomerulus and 90% is reabsorbed by the proximal tubule and the loop of Henle. Renal regulation of potassium, concentration gradient of potassium at the distal tubule and collecting duct, the distal tubule flow rate and distal tubule sodium delivery, the action of aldosterone, and changes in pH causing acidosis or alkalosis. Hypokalemia, a potassium deficiency, develops when the serum potassium concentration decreases to less than 3.5. Lowered serum potassium level indicates a loss of total body potassium. Factors that can contribute to this include reduced intake of potassium, although diet deficiency is rare, but this may occur in elderly patients, those with alcoholism or anorexia nervosa. Pathophysiology, respiratory alkalosis, treatment for pernicious anemia can lead to this, diabetic ketoacidosis, diarrhea, vomiting, diuretics, and antibiotics can all lead to hypokalemia. Now, with clinical manifestations with mild losses, patients are often asymptomatic. Patients may have some neuromuscular and cardiac effects, which are the most common symptoms seen. Cardiac effects are related to decreased membrane excitability, which can lead to dysrhythmias. Onset of symptoms is related to the rate of potassium depletion. The patient may have paralysis, respiratory arrest, loss of smooth muscle tone, orthostatic hypotension, constipation, intestinal distension, anorexia, nausea and vomiting, or paralytic ileus. And here's some symptoms of serious hypokalemia. Evaluation, we're going to diagnose this based off of the potassium level when we draw blood. Treatment, prevent further loss of potassium. Patients should eat some potassium-rich foods. Replacement is instituted very cautiously because you want to prevent overcorrecting and going into hyperkalemia. The rate of max oral replacement is 40 to 80 milliequivalents a day if the patient does have normal renal function. Now, with hyperkalemia, this is an elevation of the ECF potassium concentration above 5.5. Renal excretion is efficient, so excesses of total body potassium are relatively rare. Now, excess may be due to an excessive intake, a shift in potassium from ICF to ECF, or decreased renal excretion. Potassium shifts occur with change in cell membrane permeability. This can occur cell hypoxia, acidosis, insulin deficiency, with burns, patients who have massive crush injuries, or extensive surgery. Clinical manifestations listed here. They're also here on this mnemonic here for remembering hyperkalemia. Evaluation, the serum potassium levels can be greater than 5.5. And hyperkalemia, it should be investigated when there is a history of renal disease, massive trauma, insulin deficiency, Addison disease, or metabolic acidosis. For the treatment, you want to treat the contributing causes and correct the potassium excess. Calcium and phosphate, the total body content of calcium is 1,200 grams. Most of the calcium, about 99% of it, is located in the bone, and the remainder is in the plasma and body cells. Total fraction of calcium circulating in blood is small, and the range we're going to see from that in blood levels is 9 to 10.5. Calcium is a necessary ion for many fundamental metabolic processes. It's a major cation associated with structure of bones and teeth, serves as an enzymatic cofactor for blood clotting, and is required for hormone secretion and function of cell receptors. Phosphate is primarily in bone, 85%, with smaller amounts in the ICF and ECF. Calcium and phosphate balance is regulated by 3 hormones: the parathyroid hormone, vitamin D, and calcitonin. Here's just some symptoms comparing, or a chart comparing the symptoms of hypocalcemia and hypercalcemia. Acid-base balance. Acid-base balance and hydrogen ion concentration must be regulated within a very narrow range for the body to function normally. Even slight changes in the amount of hydrogen can significantly alter biological processes in the cells and tissues. Hydrogen ion and pH. The hydrogen ion concentration is expressed as pH, which represents the acidity or alkalinity of a solution. Body acids are formed as end products of cellular metabolism. The lungs, kidneys, and bones are major organs involved with the regulation of acid-base balance. And here's just a scale showing the pH scale going from acidic into neutral and over to alkaline. We have buffering systems, and buffering occurs in response to changes in this acid-base status. Buffers can absorb excess acid and base to minimize fluctuations in the pH. Most important plasma buffer systems are the bicarbonate and carbonic acid and hemoglobin. Phosphate and protein are most important intracellular buffers, and ammonia and phosphate are important renal buffers. Acid-base imbalances. Acidemia is a pH of arterial blood less than 7.35, and alkalemia is when the pH is greater than 7.45. We might have metabolic acidosis or alkalosis. With metabolic acidosis, there's a concentration of non-carbonic acids increases, or bicarbonate, the base is lost. With lactic acidosis, this happens quickly. And with the condition of diabetes, ketoacidosis, this happens more slowly. Clinical manifestations, neurological, respiratory, GI, and CV systems. Patient might have headaches, lethargy, coma, too small respirations, anorexia, nausea, vomiting, diarrhea, and abdominal discomfort. Evaluation, we're going to check the arterial blood gas, pH less than 7.35, and bicarb less than 24. Now with metabolic alkalosis, this is the concentration of bicarb is increased, usually by excessive loss of metabolic acids. Clinical manifestations include weakness, muscle cramps, hyperactive reflexes, and paresthesias. Evaluation is of the arterial blood gas with a pH greater than 7.45 and bicarb greater than 26. And this image here just compares the different symptoms you might see with metabolic acidosis versus metabolic alkalosis. And finally, we have respiratory acidosis and alkalosis. Respiratory acidosis, there's alveolar hypoventilation, hypercapnia, which is an excess carbon dioxide in the blood, respiratory center depression, paralysis of respiratory muscles, and disorders of lung parenchyma can lead to respiratory acidosis. Clinical manifestations can include headache, restlessness, blurred vision, lethargy, muscle twitching, convulsions, and coma. An evaluation is of the arterial blood gas showing a pH less than 7.35 and hypercapnia. Now with respiratory alkalosis, there's alveolar hyperventilation and decreased concentration of plasma carbon dioxide. So there's hypocapnia. Hypoxemia, hypermetabolic states, anxiety, and panic disorder can all lead to respiratory alkalosis. Clinical manifestations, irritating to the central peripheral nervous system. Patient may have dizziness, confusion, paresthesias, convulsions, and coma. An evaluation is with the arterial blood gas, the pH showing greater than 7.45, and the PaCO2 is less than 38. And here's a chart comparing the symptoms seen with those two disorders. That's all I'm going to cover for this chapter. Please let me know if you have any questions. Please remember you're responsible for reviewing the entire chapter. And I want to thank you all for your time. Have a great day.